Good morning, everybody, and welcome. Thank you for joining us today from across all the different institutions and sectors and collaborations. We're really grateful to have such a diverse group with us online today. My name is Anal. I'm a lecturer in the Department of Anesthesiology at SMU and the Research and Development Manager at Safe Surgery South Africa. And I'll be serving as to help guide the program along for today's launch. Just a few housekeeping notes before I hand over for the official welcome and introduction. We really like to encourage engagement through the Q&A and chat functions of the webinar. I will be monitoring the chat and help facilitate any questions or discussion points for the speakers where time allows. Please do keep your microphones muted though, unless invited to speak, to just reduce noise during the meeting. We hope that today reflects not only on the launch of a new unit, but also the strengthening of a collaborative platform. So without further ado, it's my pleasure to invite Professor Mapaseka Seheri, the Director of Research, Postgraduate Studies and Innovation at Sefako Makato Health Sciences University, to deliver the official welcome and opening remarks. Thank you, Prof.
Thanks, Program Director, distinguished guests, our speakers, esteemed colleagues, partners, stakeholders, and ladies and gentlemen, good morning. It is my great honor and privilege to welcome you all to the official launch of Bophelo Unit for Equity, Intelligence, and Learning. And this is a significant milestone that marks the beginning of the new chapter dedicated to equity, intelligence, learning, and transformation in healthcare. And we are deeply honored by the presence of our distinguished guests and speakers, nationally and international. We have Prof. Chu from University of Stellenbosch, Dr. Van Zyl from Northwest University, Prof. Salome Maswime from University of Cape Town, and Ms. Natalie Zimmerman, the CEO of Plus. And internationally, we have Dr. Yusuf Saad from University of Namibia and Prof. Beckett from Oxford University. We are also extend our sincere appreciation for our colleagues and stakeholders from public and private sectors, academic institutions, professional society, research collaborations, and international partners who have joined us for this important occasion. And today is not simply the launch of the new academic unit, it is establishment of a collaborative and forward-looking platform committed to advancing equitable surgical, preoperative, emergency, and critical care through research, learning, partnership, and system strengthening. And Bophelo Unit is grounded in a powerful vision, the one that recognizes that access to quality healthcare is a fundamental human right. And this unit seeks to advance the right to health for all by generating actionable intelligence, building institutional and workforce capacity, and informing policy and practice through meaningful use of data. And what makes the Bophelo Unit particularly unique is its embeddedness within under-resourced communities and health systems. And in many low and middle income settings or countries, health information systems remain fragmented, underfunded, and disconnected from frontline realities. But Bophelo Unit respond directly to these challenges by bridging the data equity gap and ensuring that data becomes a tool not for reporting, but improving the lives, strengthening the services, and transforming systems. And through practical needs-based data, digital health innovation, workforce development, implementation science, and quality improvement initiative, The unit aims to create a pathway through which evidence can meaningfully inform clinical care, facility management, policy development, and broader health system reform. And importantly, the unit is also committed to ensure that innovation is not merely imported, but developed within and is rooted in the lived realities of communities and healthcare workers, informed by local knowledge and strengthened through collaboration across disciplines and sectors. And as it reflected in today's program, and the caliber of speakers and participants gathered here, the Bophelo unit aspired to be a collaborative, outward-facing, and social responsive. It seeks to create space where clinicians, researchers, educators, data stewards, policymakers, students, and communities can work together to address the long-standing disparity in healthcare access and outcome. And this launch, therefore, represents more than a ceremonial event. It signals a collective commitment to build a learning health system that are equitable, data-informed, community-centered, and capable of transforming surgical and pre-operative care across South Africa and the African continent. And we are confident that the conversations, partnership, shared learning emerging from today's engagement will lay a strong foundation for impactful collaboration and meaningful change. And colleagues, once again, thank you all for your presence, your support, your commitment for advancing equitable healthcare and health system transformation. And I wish you an engaging, thoughtful, and success program. And thank you very much, Program Director and colleagues.
Thank you, Prof. Seheri, for helping frame the significance of this moment and the broader vision surrounding the unit. Moving into the first part of the program, I'd like to now welcome Professor Hella Clates, Head of the Department of Anesthesiology at SMU and also Head of the Bophelo Unit, to speak a little on the origins of the unit and the system challenges that gave rise to it.
I was speaking along and I didn't realize I was muted. Can you believe it? Morning, everybody. It's great to see so many friends and colleagues here on the platform. Thanks, Anel, for the introduction. Thank you, Prof. Seheri, for those kind words of introduction. I've spent a long time thinking about what this launch should mean and perhaps more importantly, what it should not mean. I didn't want this to become just another academic event where we present our strategic plan and celebrate ourselves for a few hours and then return unchanged to the realities we face every day. Because the truth is that the very disturbing realities experienced by patients and healthcare workers in South Africa, and particularly within surgical and perioperative care, are becoming increasingly difficult to ignore. And yet, despite this, I do remain truly hopeful, not because these challenges are small, but because I still believe that meaningful contribution and meaningful collaboration and meaningful change are possible And I think that belief is really where the Bophelo Unit began. Not in a document or in a proposal, not in a funding application, but in a growing realization that I think many of us have probably experienced in different ways over many years. This realization that despite extraordinary expertise and commitment and effort across our healthcare system, we are still struggling to make meaningful and sustainable progress. Over the past decade or more, I have increasingly found myself trying to understand a contradiction. How is it possible that we have talented clinicians, we have committed academics, dedicated nurses, managers, researchers, and trainees, and yet our systems just continue to fragment and deteriorate and struggle to improve? How is it possible that in many of our academic public sector institutions, excellence no longer feels stable or even sustainable? How did we reach a point where dysfunction has come so normalized that many things which should outrage us no longer even surprises us? And perhaps most importantly, how do we continue building and how do we continue contributing meaningfully despite all this? And these questions have shaped much of my professional life, even before I fully understood that they were actually shaping it. So for me, many of these reflections emerge from working in the public sector, particularly within an academic environment that sits right at the intersection of profound need, enormous potential, and persistent inequity. As many of you know, our hospitals serve patients across provincial borders and across vast socio-economic differences. Every day, we see both the strength and the fragility of our systems. And over time, I realized that many of the problems we were facing could just not simply be explained by lack of resources alone. Of course, resources matter. Infrastructure matters. Staffing matters. But there was something deeper happening. We were struggling, not only with shortages, but with fragmentation. Not only with constraints, but with disconnection and isolation. Not only with implementation, but with our ability to learn collectively from the realities around us. And one of the earliest experiences that influenced my thinking was my doctoral work in perioperative risk and outcomes. So what struck me at the time was actually something very simple. Even relatively modest amounts of meaningful clinical information could significantly improve how we plan perioperative care for patients. Risk stratification, pathway planning, thinking ahead, using data to guide decisions. And these ideas seemed obvious to me, and yet I became increasingly aware that although generating intelligence was important, systems do not automatically absorb that intelligence. Data alone does not create the change. Research alone does not improve the systems. Publications alone do not transform the care. And I think this insight became one of the foundational ideas behind the Bophelo Unit. Because over time, I saw these patterns repeat itself. Projects would emerge and individuals would work extraordinarily hard. And small groups would try to innovate and pilots would begin. And too often, these efforts remain isolated. An isolated effort is incredibly difficult to sustain. So some of the most important lessons I learned actually came from projects that were deeply frustrating. The Perioperative Shared Health Record Initiative taught us how difficult it is to truly hear and integrate the voices and experiences of our patients within our systems. Our work around perioperative minimum data sets and surgical indicators taught us another difficult lesson, that clinicians alone cannot carry the burden of building sustainable intelligent systems, while simultaneously trying to survive these overwhelming service environments. At the time, we believed that if we develop the right indicators and the right tools, implementation would naturally follow. But systems are more complicated than that, and perhaps more human than that. Because systems do not learn automatically. People learn, teams learn, communities learn, institutions learn. Or sometimes they stop learning. And I think one of the greatest dangers we face is not only dysfunction itself, but the normalization of dysfunction. The gradual acceptance of things that should remain unacceptable. The acceptance of delays, the acceptance of fragmentation, the acceptance of inequity, the acceptance of environments in which people slowly lose the energy and belief that meaningful change is possible. And at the same time, some of the most hopeful moments in my career came through collaboration. During my time with the South African Society of Anesthesiologists and through engagement with the World Federation of Societies of Anesthesiologists, I was exposed to a much broader global perspective. I appreciated how isolated we had become, not only from the rest of the world, but in many ways from the rest of Africa. And through initiatives like the African Perioperative Research Group and the African Surgical Outcome Study, I saw something profoundly important. I saw what becomes possible when people begin learning together across institutions and across countries and disciplines and systems. Not because anybody had perfect solutions, but because collaboration itself became infrastructure for learning. I think that changed my thinking permanently. It helped me understand why the field of global surgery and health system strengthening resonated so strongly with me. Because ultimately, surgical system strengthening is not only about surgery. It's about relationships, coordination, learning, trust, workforce development, communication, implementation, and the ability of systems to respond intelligently to the needs of the people they serve. And over time, I also began to understand something else that I believe is critically important for South Africa. Investment in surgical and perioperative care is not only a healthcare issue, it is also an economic issue, a workforce issue, a development issue. When surgical systems fail, the consequences extend far beyond hospitals and operating theatres. People remain unable to work. Families lose income. Disability increases. Caregiving burdens increase. Communities lose productivity. And health systems become progressively more expensive and less responsive over time. At the same time, delayed access to surgical care, fragmented systems, poor coordination, weak continuity of care create inefficiency that affect both the public and the private sectors. And I think this is something we still do not fully appreciate in South Africa. High quality, equitable surgical care is not a luxury. It is part of the infrastructure of a functioning society. My own experience working across both the public and private sectors and through engagement with initiatives such as Care Connect HIE reinforced for me how important integrated health intelligence and coordinated systems are, not only for improving care, but for improving how resources are used across the health system as a whole. The loss of structures that support integration, continuity, and learning within healthcare systems carries consequences that are far greater than individual projects alone. And I think this is one of the reasons why the Bophelo unit must ultimately remain multidisciplinary, because solving these problems requires much more than clinicians alone. It requires collaboration with implementation scientists, engineers, economists, data scientists, policy specialists, health system leaders, and communities themselves. And at the same time, another understanding emerged for me personally, that we cannot continue trying to fix things alone. And I say this as somebody whose natural inclination has often been to work independently. But over time, I learned that isolated expertise is not enough. We may have brilliant ideas. We may publish important work. We may identify system failures very accurately. But if we do not create structures through which people can learn and contribute and build together, very little changes sustainably. I think becoming head of department also influenced this awareness substantially, not because leadership positions themselves are important, but because I began to understand the power of creating space for shared things, shared direction, shared purpose. And perhaps even more importantly, I began to understand how many people still want to contribute meaningfully, despite difficult conditions. And this became profoundly important to me, because one of the greatest losses within our system is not only the loss of resources, it's this gradual loss of people who still care deeply about academic work, public sector contribution, teaching, systems improvement, and collaborative learning. People leave. People disengage. People become exhausted. People stop believing their contribution matters. And yet many still want to remain connected to something meaningful. And this includes colleagues in the private sector, young specialists, and researchers, and trainees, and collaborators from other disciplines, and policy partners, and managers, and community-linked practitioners. There are many people who still want to contribute to improving surgical and perioperative care, but who need a structure through which that contribution becomes possible. And I think this is ultimately why the Bophelo unit became necessary. Not simply as a research unit, not simply as an academic structure, but as a platform for equity, for intelligence, for learning, for implementation, for collaboration. A platform grounded in the realities of the communities we serve. A platform that recognizes that data matters, but that data must ultimately support people, systems, and care. a platform that creates opportunities for collective learning rather than isolated effort, and a platform that brings together education, system strengthening, implementation science, policy engagement, and collaborative research within real-world environments. Importantly, I believe there is something uniquely valuable about building this work here at SMU and within the system surrounding us. Not despite the challenges, but because of them. If we can learn how to strengthen systems within environments of complexity and inequity and constraint and fragmentation, those lessons become genuinely meaningful. Not only for South Africa, but for many other parts of the world facing similar realities. Today's launch is therefore not the conclusion of a project. It is the beginning of a shared effort, an effort to create structures through which people can continue contributing, an effort to strengthen how systems learn, an effort to connect intelligence to implementation, and ultimately to an effort to improve surgical and perioperative care in ways that are equitable, collaborative, and sustainable. But perhaps most importantly, it's an effort to bring people together who still believe that improvement is possible. People who still believe that academic work should matter, that public sector systems are worth strengthening, that collaboration matters, that data should serve people, and that meaningful change is still worth pursuing, even when progress feels slow and conditions feel difficult. The Bophelo Unit is not an answer to all these challenges, but it is an attempt to create a space where learning, contribution, collaboration, and transformation become more possible. A space where people from different disciplines, institutions, sectors, and communities can continue building together rather than in isolation. And perhaps that is ultimately what gives me hope. Not the idea that any single project or institution will solve these problems alone, but the possibility that if we learn together and work together and remain connected to purpose, can begin to build systems that are not only more effective, but also more humane and more responsive and more equitable. That is the work we hope the Bophelo Unit will contribute to. And that is the work I hope many of you will choose to help us build together. Thanks.
Thank you, Prof. Clates, for that reflection and sharing your vision and hope for what we can achieve when, as you say, people continue or start learning together. I would now like to turn the program to the role that Safe Surgery South Africa has played in enabling research and collaboration and engagement across the perioperative ecosystem. And speaking to that, I would like to invite Ms. Natalie Zimmelman, the Chair of the Board of Directors of Safe Surgery South Africa, to the virtual stage. Thank you, Natalie.
Thank you very much, Hanel, Hela, and congratulations on the launch of the Bophelo Unit, and good day to everybody on board. Safe Surgery SA was initially created in around 2014 as the Anesthetic Network of South Africa. It changed its name very quickly to the Safe Surgery SA in the realization of what Hela was just referring to, that collaboration matters, and surgery involves many role players. And so it was a much more reflective definition of what Safe Surgery SA was trying to do. It was created to support research in the perioperative space. At that time, there was some data platforms like RedCap available at some universities, but not all. And they were then very specifically available only to those universities, which made it impossible for collaboration to take place, and sometimes at a fee. Research support was available as well, but also at a fee that very often exceeded the availability of the funds that the researchers were able to generate. And so Safe Surgery SA brought the resources to the team, to researchers to enable that research. The focus was in South Africa and remains on primary healthcare systems and care improvements. But surgery and perioperative environment can save so many lives. And it is also a very expensive part of the healthcare system. And the need to focus on improvements in the healthcare system in the perioperative space is being driven by the clinicians themselves and brings enormous value into the healthcare systems for South Africa as a whole. Safe Surgery SA has been the entity that has taken the initiative to provide collaborative research support and universally accessible platforms to support everything that people are doing, both in research design and implementation. It has also been working hard to provide and improve a more patient-centric and patient-driven view of perioperative care and of the systems that enable it, such as the PSHR. But creating the platforms and enabling the research is one thing. But ensuring that the data points and terminology, I remember many years just trying to identify how we speak to various outcomes and ensuring that those outcomes are universally phrased so that data is comparable and also that the data is properly risk rated has been critical. And that is where properly qualified clinicians in the perioperative space has been so very valuable, and where Hala and the dedicated team have provided unbelievable amounts of time. And for all of these investments in system platforms and research support to be effectively used, Safe Surgery SA has also supported and enabled the collaboration. Collaboration in South Africa, across institutions, across the public and private sector, but also well beyond South Africa through the support of platforms like the African Perioperative Network and also the African Perioperative Research Group. But the work is not only about research. It's about improving patient outcomes. We mustn't forget that patient outcomes is at the center of everything we do. And to do that, we have to strengthen the healthcare systems and support equitable access to quality surgical care. And by doing that, we also need to enable data-informed healthcare improvements in these very resource-constrained settings that we are sitting in at the moment. The volunteer time that has been contributed by clinicians such as Hala, by the universities and university infrastructures, and the support of institutions like SMU in the creation of Bophelo Unit is what is enabling this data-driven healthcare systems improvements. And I think that we must be very grateful and impressed by the work that the team is doing. It's why the board gives its time and effort from numerous different fields to support the healthcare improvements. I think that Hala, Safe Surgery SA, the Bophelo Unit make a real difference in the world we live in and the healthcare that we all want to access and our own cost of living in doing so. So I thank you for this opportunity to speak on Safe Surgery SA, the work that it has been doing that is so critical, and to congratulate you and the team on the creation of the Bophelo Unit. And I've made you up some time, Hanel.
Thanks, Natalie, and thank you very much for your message as well. The next part of the program focuses on the African Perioperative Research Group and what collaborative perioperative research across Africa has been able to demonstrate in practice. Unfortunately, Professor Bruce Picard, the director of the African Perioperative Research Group and Nuffield Professor of Anesthetic Science at Oxford, couldn't be here today with us live, but he recorded a short message for the launch, and I'll play that now if you can all just bear with me for 2 minutes.
Good morning. Thank you for the opportunity to present a short message today. I'm sad not to be able to attend in person, although I'm very much here in spirit. The establishment of Bophelo is a significant step in moving towards health equity in Africa. I've been fortunate to walk much of this path with Hela, Safe Surgery, and colleagues across Africa who are interested and engaged in improving surgical outcomes. At this point in the program, I believe you would have already heard about the lack of a system-level intelligence and coordination in surgical care, which was the original impetus for Bophelo, and Safe Surgery South Africa, which has been a platform that's enabled collaboration and supported perioperative research across South Africa and more broadly Africa. I want to now focus on APORG, or the African Perioperative Research Group. So what is APORG? APORG is a network of clinician investigators which formed across Africa in 2015. This collaboration has gone from strength to strength and now embraces 43 countries in Africa with nearly 2,000 clinician investigators. What have we found? APORG has enabled an understanding of surgical outcomes in Africa. We now know that if an adult has surgery in Africa, they're twice as likely to die than if they had surgery elsewhere in the world. We know that mothers who have cesarean sections are 50 times more likely to die than if they had a cesarean section in a high-income country. We know that children are 10 times more likely to die when compared to high-income countries. And we also know about critical illness in hospitalized patients. We know that 1 in 8 patients in hospitals in Africa are critically ill, of which 1 in 5 of these patients will be dead within 7 days. It is really through these large prospective studies with simple but high quality data that have enabled us to understand the risk factors associated with mortality, with surgery and critical illness in Africa. We now know that how patients die after surgery in Africa. Nearly 95% of patients die postoperatively on the ward. What happens is they develop complications and these complications progress to death. This is known as failure to rescue. Although the complication rate is similar in Africa compared to the rest of the world, the mortality following a complication is excessive. In other words, it's excessive failure to rescue. This led us to an attempt to decrease these deaths through a massive clinical trial across Africa, where we tried to increase postoperative surveillance to identify the deteriorating patient. We recruited nearly 30,000 patients, but we failed to change outcome. It was this failure that's taught us a lot about understanding how patients do in Africa and the determinants of mortality. We now know that knowing what the risk factors alone is not necessarily enough to improve patient outcomes. It was this failure in our clinical trial across Africa which has allowed us to further understand what is needed to improve patient outcomes in the future. We have learned the following, and it is here that Bophelo will be able to take us forward. Half of patients' outcomes or mortality can be explained by patient and surgical risk factors and the complications they develop postoperatively. However, the other half of mortality, which we cannot explain, is dependent on the context and the environment in which the patient sits. And it is here that Bophelo will be able to contribute to improving patient outcomes. A health system is complex. It's composed of resources, people, and processes. And to effect change to improve outcomes, we need to coordinate all of these and optimize their performance. Data is central to the success of these interventions. It has characteristics which are essential for care. We need to be able to track the risk factors for accurate risk adjustment. We need to be able to track the processes necessary for the delivery of quality care. And we need to track patient outcomes, not only mortality, but outcomes associated with the quality of life of the patient. We need more structured platforms like Bophelo going forward. I wish Hela, SMU and Bophelo all the best and every success in this new and important phase in striving to understand and improve patient outcomes in South Africa and more broadly Africa. I wish you well. Good luck.
Okay, having reflected on the collaborative foundations, I'd like to now turn toward the strategic direction of the Bophelo unit itself. And to this end, it's my pleasure to invite Dr. Inge Kleinhans, a public health medicine specialist and the Bophelo unit manager, to the stage.
Thank you so much, Hanal, and good afternoon, colleagues. Thank you so much for joining from wherever you are. We are absolutely grateful and honored to have you online during this this momentous moment for us in the history of the Bophelo unit as we launch today. Please allow me to share my screen. Hanal, can I just confirm that you are able to see my slides?
Yes.
Perfect. Thank you so much. Thank you. Good afternoon, colleagues, once again. It is my absolute honor as unit manager to share this afternoon our strategic direction for the Bophelo unit in order to drive the advancement of equity, intelligence, and learning in surgical systems. I'll briefly touch on what we are aiming to build, our core strategic purpose, the different work streams that we aim to design to carry out our mandate, and what this would look like operationally. Ultimately, also briefly touching on how we aim to sustain and grow this platform. I'm standing on the shoulders of all the speakers that has gone before me and really want to highlight the fact that the Bophelo unit is not just another research group training project or a policy voice. It really is a platform that provides a home for multidisciplinary groups to come together collectively so that we produce evidence, tools, and practical learning for surgical, emergency, critical, and perioperative care. We aim to ground this in community, drive this through data, and orientate this towards sustainable and transformative surgical systems. We also aim to have this unit be embedded in a system that develops people while creating opportunities, using real systems, real data to inform implementation strategies leading to true impact and tangible transformation. And lastly, we aim to also build a unit that is a bridge between academic evidence, frontline realities, our data systems, and decision-making for safer and equitable surgical and perioperative care. Our strategic purpose is to strengthen surgical and perioperative systems through data-informed research, education, implementation science, and policy engagements. We aim to do this through generating intelligence, as previously mentioned, by using data effectively and making sure that we understand the capacities we are working with, such as facility assessments, looking at outcomes research and educational research, and lived system experiences to eventually show the need and the gaps that needs to be filled and planned for in the surgical system so that it becomes visible and measurable, because we cannot plan for what we don't measure. We also want to drive building of capacity, both for the development of people, but also teams within the surgical and perioperative spaces across the multidisciplinary fields and institutions through embedded supervision, short learning programs, workshops, tools, and collaborative practices. And then lastly, we also aim to inform action that is driven by evidence that forms into implementation, that drives quality improvement, that leads advocacy and policy at an entire systems level, and that transforms it into accountable, resilient, and sustainable systems that we build and develop together. Ultimately, evidence can be used, learning that can be shared, and partnerships that is created for change. Since 2015, surgery has been brought to the forefront of global policy and advocacy efforts through the landmark 2015 World Health Assembly Resolution, which formally recognized emergency and essential surgical care and anesthesia as fundamental components to achieving universal health coverage and health for all. This was further strengthened by the formation of the Lancet Commission of Global Surgery and the Utstein Surgical Indicators later released. This year, the draft Global Strategy for Integrated Emergency, Critical and Operative Care was released for 2026 to 2035. And it was supported vigorously by the 2023 and 2024 World Health Assemblies that called for action and a tangible policy to inform or strategy to inform our efforts as signatory members to the World Health Assembly. Many countries have since started working towards different policies and programs and frameworks. They've revised and adopted these and then also implemented them into practice based on their contextual need. And so we hope to provide and build towards the foundation of this within the South African and African context. South Africa's quadruple burden of disease will not be fully addressed without safe surgical and perioperative care, as this is embedded across the life course of our people and populations, with many of our diseases requiring either preventative, urgent, or emergency surgical intervention. Its contribution to preventable deaths and morbidity can no longer be ignored, as it has a tremendous impact on our social economic status of the population at large. And this affects not only the health, but also the living conditions, work abilities, and the ability to be healthy and prosperous of our people and communities. Therefore, our unit grounds ourselves within a health systems approach across the multidisciplinary collaboration that we aim to build within this unit to address leadership and governance towards surgical systems, building, establishing, strengthening, and using health information systems, to work towards financial strategies and resource allocation for surgical care and programs, towards quality, timely, and accessible, equitable service delivery, and investing in our human resource capacity, not just our surgical workforce, but all the disciplines involved in effective surgical and perioperative care pathways. And lastly, to look at medicines, products, and vaccines that are necessary within the surgical care continuum so that we ensure that this is provided for our people across our country and making sure that there is ultimate access for health and health for all. So our work streams aim to achieve 4 key entities, but ultimately, even though there are 4 of them, we aim to have one integrated mandate. First of all, we want to look at working towards intelligent and data systems where we build, develop, and manage knowledge bases, dashboards, collect routine data, and work towards measurable surgical indicators that become routine, and ultimately also being able to produce real live data use cases to drive safe surgical care. We also want to have a work stream that focuses on systems, strengthening and implementation science through measures such as, for example, looking at our facility capacity and assessments. We want to work through outreach programs with our cluster hospitals and referral centers to understand the surgical need and quality improvement programs that eventually are able to inform policy translation. We also want to embed our work within the capacity building of our human workforce, and this will then be done in the form of education and workforce development. This will be done in terms of short courses, postgraduate programs, and building best practices through community of practice. And then lastly, but not the least, the establishment, as said before by previous speakers, of collaboration and networks for change This can be either internal through Mokgotjo Health Sciences University, other South African universities, the Ministry of Health, both in country and out of country, the Office of Health Standard Compliance, the Safe Surgery South Africa, Safe Surgical Care Technical Working Group, APOG, University of Namibia, and so many others. So if we dig a little bit deeper into the workstream on intelligence and data systems, the idea is to go from fragmented systems and data to decision-ready knowledge that can be used at the tip of a finger by decision makers and policymakers. Ultimately, data is not an endpoint, but it must become valuable when it is transformed into knowledge, and this supports clinical practice, facility management, and policy accountability. Our work towards this will focus on clinical data and perioperative knowledge bases as supported before, through development of practical needs-based data use cases, routinely collected data, and supporting fair data principles, and making sure that data is harmonized, not fragmented, and reusable to transform outputs and inform decision-making. We want to also strengthen the visibility of surgical systems through surgical volume, perioperative mortality rate, and facility capacity, and drive equity-relevant measures. Like said before, if it's not measured, it cannot be planned for. And then lastly, we want to focus on the ethical data stewardship principles, which is imperative when working in intelligence and data systems. We want to make sure that there's good capacitation of digital literacy, governance of data use, data quality, and responsive use, especially in under-resourced settings. So we end up asking ourselves, what do we need to measure in order to learn, improve, and act on towards safe surgical systems? In terms of our system strengthening and implementation science workstream, we aim to embed our work in understanding the system's readiness, the capacity, our infrastructure, referral pathways, and workforce gaps, and the practical constraints that is currently in our systems that impacts the care and service delivery to our patients and populations. We want to make sure that our implementation-focused projects are designed to move beyond describing the problems, but coming up with feasible solutions that can be tested, adapted, and embedded within context, and that we include the community and patient engagement systems to inform improvement priorities. Lastly, we also want to work towards policy and program engagement through engaging hospital services, different NHI processes, the safe surgical care structures, and provincial as well as national decision-making. And then building academic platforms that lead and hospital clusters that builds a living laboratory to inform educational needs and development, quality, and implementation. The key here is that implementation is not an afterthought, but it is part of how knowledge is generated and used. In terms of our education and workforce development, we aim to build on 4 key pillars such as exposure, capability, contribution, and leadership towards surgical systems and the workforce. So in terms of exposure, we're going to invest in the development and rolling out of webinars, CPD programs, and overall awareness campaigns. To strengthen capability, we want to develop short learning programs, build postgraduate programs that has a safe surgical care or surgical care and perioperative care element or module to it. We want to develop and frame workshops that addresses the capacity building and also ensure that we enhance digital literacy and quality improvement skills amongst our healthcare workforce. In terms of our unit's contribution, we also want to ensure that there's adequate Masters of Medicine support, research teams that are built and strengthened for impactful outputs, and that it's not merely just a tick box exercise, but it has true knowledge and policy impact. And we want to also work towards the building and establishment of dashboards, facility assessments, and policy briefs. And lastly, but not least, we want to develop and invest in leadership throughout our continuum of students and staff supported through supervision, regional collaboration, implementation of leadership and governance, and also academic outputs. it is part of our operational platform as it provides a key element in the health systems framework approach that we aim to take, such as the fact that we want to invest in the workforce, because that, at the end of the day, with our leadership, governance, and information systems, drives safe surgical care. So as mentioned before, we want to develop quarterly short learning programs for perioperative data, quality improvement, and surgery and implementation methods. We want to also focus on the nursing and anesthesia care pathways, where we ensure that there's certification and future postgraduate diploma opportunities linked to anesthesia services and collaborative efforts. Again, as mentioned, the postgraduate research support through not just support, but throughput, publication, and also impactful outcomes. We want to also invest in the foot soldiers of the health system, our community health workers, and develop their learning, training towards surgical and perioperative care within communities to make sure that that gap is bridged in the surgical care pathway, and develop learning products and toolkits that are able to be reused, of dashboards that can be seen in real time, contribute towards policy and advocacy efforts, and then also ensure that there's ample evidence that is generated to inform decision making. Lastly, just to highlight our work stream on collaboration and networks, and this is just a repetition of what has been said before, but we really want to be a platform that convenes all these partners and collaborators to collectively achieve surgical care pathways, surgical systems, and make sure that that is embedded within the health system to create health for all and sustainable health systems that can serve our population's needs. So operationally, how will we know if we are successful down the line? Essentially, we want to make sure that our platform is multidisciplinary and that it is embedded to create an entity of collaboration and service delivery. We want to ensure that there's collaborative platforms with co-developed priorities and outputs. We must be intentional about partnerships and collaboration to ensure that that is done collectively and not in parallel or siloed systems. We also need to make sure that we have a reality check and make sure that our work drives real-world system engagement, not just theoretical, but what is really necessary on the ground in frontline environments, and make sure that it's fit for purpose and contextual. And then lastly, implementation-focused work to drive our projects not just towards outputs, but make sure that these outputs eventually lead to quality improvement, educational advancement, and policy strengthening. Essentially, we will measure ourselves in terms of success if we can make sure that we are a mechanism for turning relationships into outputs and outputs into systems value. Our sustainability and future growth is imperative, as we don't just merely want to have a launch, but want to build a unit that is sustainable past our tenure. We need to make sure that there's ample governance and accountability embedded within our internal systems, that we have diversified funding through grants, career development pathways, and educational activities, as well as publication incentives as an example, but also invest in the people that is required to make this work and the infrastructure that has to go with that. Ultimately, sustainability is not only financial, but it needs to be intellectual, relational, operational, and institutional for us as a Bophelo unit. We know this is working, as mentioned before, if we can make sure it's a living, useful unit through the outputs of decision-ready intelligence, making sure it's a growing learning community of multidisciplinary practitioners, that we have implementation outputs and visible academic productivity. And then lastly, we cannot achieve this without having an embedded strong partnerships and collaboration platform. So I leave you with this. Bophelo is our commitment to build the intelligence, capability, and partnerships needed for equitable surgical systems. Authentic solutions to real-world challenges that are fit for purpose and contextual towards resilient surgical systems. And also lastly, as an African proverb, I want to proudly leave you with this thought. If you want to go fast, go alone. If you want to go far, go together. I call on each and every one of you to find an area of contribution, collaboration, or partnership, and we look forward to working with you. Thank you so much. Over to you, Chair.
Thank you so much, Inga, for framing how framing how research and data implementation, education and collaboration may be used to advance equity, intelligence and learning through the Bophelo units moving forward. To reflect on strengthening academic collaboration for global surgery and health systems equity, I'd now like to invite Professor Catherine Chu, the Director and Professor at the Center of Global Surgery at Stellenbosch University, to the stage.
Thank you so much, Hanel. I first just want to say congratulations to the official launch of Bophelo. I think this is extremely exciting, and it's so nice to have another global surgery unit here in South Africa. So as Hanel said, our Center for Global Surgery is based at Stellenbosch University. We were established in 2019. And our core business is research. In the last 6 years, we've had over 180 publications, and we hold about a dozen international grants. We also do teaching. We offer a master's in global surgery by research, and we have short courses in global surgery research skills, and we're currently putting together an online humanitarian surgery course. I will post the flyer to our latest course in the chat. But I think overall, the important point is that we hope to be relevant to policy and clinical practice. I was asked to speak a little bit about academic collaborations, and I'll just share my thoughts of what we've learned and are still learning over the years. I think that first is, in terms of academic collaborations, to find collaborators within your own university, but in other departments. And I think this is quite important because funding specifically for global surgery or improving surgical health systems is really, really sparse. But there are other funding calls, for example, for improving data infrastructure, definitely now around big data and AI. And if you can establish these collaborations before a grant call comes up, it really, really helps a lot to have had those preliminary conversations, to at least loosely discuss like some kind of research concept, because sometimes these calls come up and you have very little time to apply. And I think particularly collaborations around with schools of data science is really relevant to Bophelo based on what Inga was just saying about some of the objectives of the unit. The other collaborators I found really helpful are health economists and the climate change folks, because again, these are areas where surgery as a health system also impacts, but may not be collaborators that we think of like right away. Another group that we have found at least very useful to collaborate with are local NGOs. So a lot of our work focuses on the upstream factors around access to surgical care. And we find that collaborating with local NGOs gives us access to populations that we wouldn't necessarily know about if we just focused on in-hospital work. So, for example, we've been doing work with community healthcare workers and indigenous knowledge healers, and these connections were made through local NGOs. One was an NGO that actually delivers work with community healthcare workers, and another one is an NGO working with injured persons living in rural communities. But these were connections that helped us sort of open doors to working with these populations. In terms of international collaborators, because I think oftentimes we in South Africa are looking for collaborators outside our own countries. In-person meetings are expensive, but it is a great place to network, to find connections. And I do think that networking is a little bit like speed dating. You'll meet a lot of people and you'll click with just a few of them. But when you do click, it can really work out, but you might not click with all of them. So don't stress if you talk to people and you didn't really think that their idea and yours really matched. One of our biggest collaborators is somebody that I met at a VITS meeting around global surge in 2015. So that was a number of years ago. I just want to say for Bophelo that you are in a position of strength when it comes to international collaborators. And I don't always feel like we think of ourselves that way because we sometimes feel like we're on the back foot. Some international collaborators come in with a lot of methodologic expertise. They've written a lot of papers, they've gotten a lot of grants, but what they don't have is access to the patient populations in Africa or low and middle income countries. And at least for the moment, that's what global surgery is about. It's very hard to write about or do research on populations and LMICs if you live in a high income country. So just remember that you are in a position of strength when you talk to different collaborators. But again, it has to be a good fit. I think the other advice is that if they come with their own proposal of a research project, make sure those objectives are relevant to what you feel is important in your own space. Sometimes people come or potential collaborators come with ideas and it's what the funder wants to pay for. So it might be a project around morbid obesity, for example, which is a problem in South Africa, but not necessarily one that our center is focusing on. So just make sure that the research objectives are relevant. I think the other issue or the other component to remember is that when you do write a grant together, make sure that capacity building for your team or yourself is built into the grant. Because again, if we don't have that methodologic expertise or that grant writing expertise, we want to come out from the grant cycles with improving that. We don't want to be in the same position every time. So to give one example, maybe a decade ago, I was a collaborator with a certain PI. So I was not the PI, I was the collaborator. But over time, I became a co-PI, and now I am the PI on some of our applications. And so I think, make sure that that gets built in. It's sometimes a little difficult to ask right off the bat, but I think if you don't ask, then you won't get it. In terms of the funding sources itself, the funding is difficult to get, but start with small pots, especially offered at the university or like local or national society groups. Sometimes they offer, 50,000 Rand, 100,000 Rand, and these are much easier to get and you don't have to be as polished initially. But they can really get some of the work started and to build that grants resume. Because oftentimes when you go for the international applications, you need to show that you've been doing stuff. And what is that stuff? Well, just to get started, you can apply for the small bits. And also a lot of the research you can do without any research funding at all. It's just about talking to people and analyzing what little data there is available. So I think one must be creative early on. And then finally, just to say, it seems like the funders more and more are looking to work with consortiums. So consortiums across South Africa and Africa, I think, could really be a position of strength. And I think there are several people on the call who are also heading up other global surgery units. And, Bophelo, I think, is very well positioned, for example, in South Africa, because SMU is a historically disadvantaged institution. Stellenbosch, UCT, WITS, for example, are not. So they're often looking for partners, especially to lead the application. So I think you would be very well positioned, Bophelo, to lead those. And then my final thought is just to maintain clinical and policy relevance. I think it's so easy to work in your research silo, and sometimes even in your own hospital or institution, the clinicians don't know what you're doing. And I think that if you don't make your work relevant to them or make that the clinicians feel included, it could be very isolating and it's not to your advantage. I think presenting at hospital clinical meetings, M&Ms, just to either educate them about what is surgical health systems strengthening or what is the work one does, they can also give a lot of great ideas, but also make them feel included. So they will also help champion you. And so if there is some opportunity for collaboration, sometimes it's the clinicians that will be the ones to put your name forward. And then finally, of course, the policymakers, they're busy. Sometimes clinicians also feel like they don't have any relevance to what the clinicians are doing at the coalface, but the same with research. You kind of have to insert yourself and get time in front of the policymakers and say, this is what we're doing. How could our work be useful to you? And that's all I had to say. I just want to wish you the best of luck and thank you so much for the invitation to speak.
Thank you so much, Prof. Chu, for your valuable advice and insights as well, coming from learnings from within your own unit. I think one of the strengths of the Bophelo unit vision is its multidisciplinary nature, including perspectives beyond the traditional clinical disciplines. And to this end, I would like to invite Dr. Maria van Zyl, a senior lecturer at the School of Industrial Engineering from Northwest University, to share an engineering perspective on designing data-driven surgical systems.
Thank you very much, Hanel. I'm really excited to be part of this team. And I think for us, you know, when we started to see what the collaboration could do, we were really on board because, you know, it's such a good thing to have a vision where we know as engineers we can contribute so much. And I would like to today basically take you through some of the thinking that I think engineers can contribute here to actually improve surgery systems. So I'm going to first show you about, let me just see if my slides are not, just hang on a second.
We did see your slides, Maria. Was it not moving?
No, it wasn't moving. There we go. You see my slides now?
Yep.
Okay. So basically, in an engineer world, we see things as something having an input, something going through a process and then having an output. And within this process, we often have systems within the systems. And our view, sorry, something strange is going on with my slides. In our view, we look at, if we had to look at the surgical system and specifically surgical and perioperative care, we would want to see data going into the system, something being done to that data, and then getting answers and outputs. And we basically want that outputs to mean something, to change the process. I know Prof. Haler spoke in the beginning about, you know, it's very easy to have a lot of data, but in the end, it doesn't really do anything because we just sit with the data. It doesn't change the system unless we go and act and change the system. And I would specifically want to talk, if you look at this model, talk about the process and models that us as engineers actually work on. So in an ideal world, and you must remember the ideal world for an engineer is a world where there's lots of data available. In the ideal world, what we could do in a system like this is first of all, take the data and either look back, and looking backward would be looking at analysis, telling us on dashboards what happened. But we can also look forward. We can also do predictions. Okay, and this is where we can use tools these days that are really popular and making a huge difference. AI, machine learning, it basically augments traditional regression modeling where we can actually say what are the predictors of or the predictors of certain events happening. We can also create digital twins and simulation. So without disrupting the healthcare system, we can take data and simulate it to see what the answers would be. Some of the answers we can give is, for example, on patient level, we can predict patient outcomes from certain indicators. At team level, we can help with giving access and operating room planning and scheduling to say, if you have a specific population, but you only have constrained resources, how do we plan and schedule the system to actually give equal care to healthcare to all? And then also making sure that the right capacity is available at the right time and the right place. And once we have this in place, once we've looked at the data, analyzed, looking back and looking forward, we then can go in as industrial engineers and change the process and improve the process. However, I'm putting a picture here of a hammer and a brain. A lot of people these days are looking at AI, looking at machine learning models, looking at how to use all of this data, and it's not difficult. If you have a data set, you can build a machine learning model in an afternoon through AI, through the generative AI. But there needs to be a brain behind it to see how does it influence the system? How does it influence the patient outcome? And that's where we as industrial engineers want to take hands with people that's got the clinical understanding and say to them, this is what we find in the data. Does it make sense from a clinical perspective? And how can we go in and help you to make the changes to the system? Now, looking forward, in the ideal world, we know it's not an ideal world. We know that there's not necessarily data. But the first thing we would want to do is, say, if we look at an element such as surgery volumes, how do we map the process? How do we map all the interconnectedness? How do we make sure that we understand the entire system and how these elements co-react to each other? That's the first thing that we would do. Secondly, like I said, we know that data is not always available. However, there are institutions like APORC, for example, they have data available. And what we can do is we can use historical data from other contexts and synthesize data to come up with answers. That will mean mapping the system, modeling the system, and then experimenting and learning from the data that we receive and seeing if it is adaptable. And that's where the clinical knowledge comes in to say, yes, your engineering model of the world is as we understand it. And then from there on, the cycle of improvement can continue. Lastly, we really believe in empowering people. There are wonderful clinicians, nursing staff, people on the ground that do excellent work, but when they gather the data, they don't always know or understand what they can do with the data. And we believe we should enable them to have basic data analytical skills, be able to know how to interrogate data, how to change processes, and then also the opportunity to have industrial engineers on the ground in hospitals looking at a process and a systems perspective to surgical care. We believe that's really where we can contribute. We do this in several industries. And like Prof. Hela also said in the beginning, you know, there's so much improvement to be done. There's so many excellent people working in the field, and yet the system is not improving. But us as industrial engineers, we really believe that we can contribute here and assist you to create better systems through data. Thank you very much.
Thank you very much, Dr. van Zyl, and also for demonstrating the value add that can come from these multidisciplinary collaborations. For the next segment, we are looking towards cross-border collaboration for surgical systems strengthening in Southern Africa. And I'd like to invite Dr. Yusuf Saad, the Acting Head of Departments of Surgical Sciences at the University of Namibia, to share his thoughts on that. Thanks.
Good afternoon, everybody. Good afternoon, Hanel. Thank you very much for inviting me into this very exciting occasion. It's a pleasure and an honor to be here. I will be very quick, and I will be just sharing some exciting experience. I hope you are able to see my slides, and I made the slides to be something. Are you able to see the slides?
It's coming up. Yes, there we go. Thanks, Dr. Saad.
We can see, then you can continue.
Is it clear on the screen, or I'm not sure if it is showing in a slideshow or whatever?
Dr. Saad, we can see it. We can see it clearly. Please go ahead.
All right. There is no conflict of this presentation. Good day, colleagues, friends, and partners. When we are looking into the landscaping of health care in Southern Africa, borders are quickly dissolving because the challenges which we face in Namibia, South Africa, and similar surrounding countries are very similar. In our clinics, operating theaters, look into the same long patient waiting list, navigate same strained infrastructure, and feel heavy burdens of critical shortage of surgical and anesthetic specialties. For too long, the default approach was that everybody is working in isolation, but putting our heads down, focus on our own national borders, and try to innovate was in vacuum. Surgical diseases don't respect borders, neither should our solutions be. The reality is that no single institution holds all the answers. And if we want to move the needle on the global surgical agenda right here in Africa, we have to share how we build together. This is why we were very privileged when the team from Bophelo came September 2025 to UNAM, where we spent 1 week to have exchanging of experiences and lesson from our senior brother and sister university in South Africa with Prof. Hila and Elise. This brings us to the very reason why we are gathering here today to celebrate this external, this very wonderful opportunity of launching the Bophelo Unit of Equity and Intelligence and Learning. It would be incredibly easy that everybody will just stand there and talk about administrative framework, but yes.
Sorry, the slides are not changing. I think you maybe just need to go ahead on your side. Sorry.
Is it moving like this?
It looks like it's moving now, yes.
All right. Sorry, apology about this.
No
so that
problem.
is that is a photo of the team came to visit us September 2025 last year. This brings us to the very reason of being here today to celebrate this wonderful occasion. This is not just an administrative framework, but this unit is a true engine. And as you see here, that very busy workshop where we were there in March this year to share experiences and working platform. It was a true experience of exchanging experiences into the global health safety. Bophelo, I understand, means life, means health, and by embedding this unit at the core of our regional collaboration, we are making profound statements and meaning regional partnership. It's not that the wealthier and the senior institute is fixing the other, but it's a mutual peer-to-peer exchange between academic and clinical institutions. And that was part of the same workshop where we were busy with March 2026. Through the Bophelo unit, we are pioneering a platform that embeds data into real-world decision-making to improve perioperative care across under-resourced settings. This unit gives us the infrastructure to take ownership of our narrative, using data to drive equitable clinical outcomes, tailored specifically for the African healthcare environment. And I see that was loaded already on the internet as part of our workshop summary. I wanted to put some memorial photos of our coming together. A brilliant living example was a vision of our active collaboration between SMU and University of Namibia, UNAM. The partnership was not only theoretical alliance in paper, but it was also a blueprint for regional systemic strengthening. And out of that, we already had our first result, which was, I don't know if you can see on the screen, it's a short course for anesthetic nurses, which was developed in collaboration as a result of this fruitful workshop together. So collaboration ended up by having this short course developed. We are ready to embark into that. Also, the application and implementation will go hand in hand with Bophelo unit members and teams as well. And this is a photo of all the people collaborated into that workshop, coming together all across the borders, which is showing this beautiful collaboration. I thank you, everybody who's putting the energy, trust, and vision into bringing this unit to this joint program to life. Let us look forward to the lives that we will be changing, the professionals who will be trained, and to the stronger health region collaboration building up together. And when I thank everybody, I want to especially thank the woman leading Africa's surgical revolution, Prof. Cletus, congratulations, all your team members, the wonderful ladies around you. All the best and congratulations again. Thank you very much.
Thank you very much, Dr. Saad, for your kind words and also for the very real example of what becomes possible when we cultivate the partnerships around us. Our next speaker will help to bring together the important relationship between academia, policy, and practice for surgical systems transformation in South Africa. And it's my privilege to invite Professor Salome Mashumi, the head of Global Surgery Division at UCT and incoming head of School of Clinical Medicine at Wits University, to this stage.
Thank you very much for this wonderful invitation. And let me take the opportunity, and let me also take the opportunity to say huge congratulations to Prof. Clates and to the entire team. I speak today both as the head of global surgery at UCT, as an academic head, and also as chairperson of the South African Technical Working Group on Safe Surgical Care, where Prof. Clates is a member and actually the lead for the surgical data system, research and information systems team, and a champion really for data system strengthening in not just in Africa, but the work that you've done is incredible globally. As mentioned, your work with the Safe Surgery South Africa, with APOC, with APRISE, in global surgery, you've been a real pillar of strength to all of us as we've looked to develop global surgery teams and groups across the country and across the continent. But I really want to talk about the importance both of academia and bridging the gap between policy and practice, and really how the Bophelo unit will and can contribute to this. And let me start with why the Bophelo unit is so important and why we are celebrating this work. I really feel that it becomes a beacon of hope for us having a research unit that is focusing on data on surgical systems, really bringing this idea of surgical epidemiology and turning it into reality, but coming up with research and answers that can inform practice and policy and decision-making. The real gap in surgical care currently is we don't have the numbers, unlike many other disciplines, where mortality rates are well understood and calculated, but the data for surgical care and surgical systems is really missing. There's a huge gap in that. And so having a formalized research unit within SMU that is going to look into this work is really going to support the work that we need to do on strengthening surgical systems. We want indicators. We want to look to indicators to define the real burden of disease in South Africa, but there's very little that is there. And Prof. Clates has led some of this work recently, publishing about the unmet numbers or unmet data needs for surgical systems in South Africa. But we really believe that the work that the unit is going to do will give us and will develop and strengthen the research that we need, not just at national level, also within hospital facilities, within regions, within provinces, but also informing data systems and strengthening data systems for the continent and contribute to the rest of the world. So I'm truly excited. I see opportunities for postgrad supervision masters, PhDs, MPHs that are looking at this work. And so as we build an academic pipeline of global surgeons or people that are interested in global surgery, this becomes an important place for people to do their research and find a research home that will allow them to do work both on surgical epidemiology, understanding surgical systems, and also using data to inform and design surgical programs at public health, for public health or at public health level. And then also, I think, as mentioned earlier, from an academic perspective, the being able to run short courses. There's a shortage of courses on global surgery across the continent. We need to improve access to global surgery education. And as mentioned already, I think this unit will also be able to provide some of that and become a place where people can also come and learn more about global surgery and take courses on data system strengthening for surgical care. So I really just want to close by acknowledging the effort, the work. I think what's exciting is you've done this for so many years. So whilst we are celebrating a brand new initiative, this is, you've got more than a decade or decades of doing this work. And this is really just to congratulate you and to say we look forward to working with you. You've already built amazing collaborations with the National Department of Health, within the different levels, directorates. So this work is already happening, but it was important to formalize it into a formal entity that we can all recognize and support. And also the incredible team that you have with Inga, with Hanel, and all the people that are involved who are already doing such amazing work within this space. So huge congratulations. We look forward to working with you. We look forward to supporting you. And we know that this is really going to open new opportunities to strengthen surgical data systems for South Africa and beyond. And we look forward to the partnerships that we'll have because of this, and also to future decisions at policy level that will be made because of the contribution of this important unit. So thank you for inviting me. Congratulations, and wishing you all the best as you embark on this journey.
Thank you very much, Prof. Salome, for your kind words and for dreaming with us for future prospects. As we come towards the conclusion of the program today, I think one of the strongest themes that has really been coming out through this whole meeting has been the importance of sustained collaboration and the collective responsibility in strengthening healthcare systems together. I would now like to invite Prof. Harold Majani, the Deputy Dean of the School of Medicine at SMU, to deliver the closing remarks for us and reflections for today, and on sustaining momentum for equity learning and the systems transformation at SMU. Thank you, Prof. Majani.
Thank you, Hannah, and good day, everyone. Ladies and gentlemen, I just rise to express gratitude to all the speakers, the organizers, and all the attendees to this launch in the form of supporters, partners, etc. Much as I thank you all for attending and honoring this invitation from the apex of my heart, please allow me to isolate the following. Professor Zaheri, thank you for sharing the broader vision of the Bophelo Unit. You really set a tone, you created a warm ambience for this launch. Prof. Clates, the anchor, the center of the Bophelo Unit. Your words were quite deep. You are indeed a visionary. You saw a void, you had a void. You saw the disconnection, inequity, the isolation, the lack of ability to learn collectively. We thank you for the wisdom and the courage, above all, to do something about that void, Prof. You are indeed a vessel to the upcoming unity, the synergy, the collaboration we are to experience through this unit. We welcome the Bophelo Unit and how it will be used to serve the community through multidisciplinary healthcare system. You and your team and everyone that is involved, you have our support. Ms. Zammelman, you enlightened us on the Safe Surgery SA, the work that has been done there. Thank you for your congratulatory message. We have no doubt indeed that Bophelo Unit will benefit from your support. Professor Bruce Bickert, although you could not join us on this online platform, your warm message was well appreciated. Now we know what APOC is all about, its impact, especially in our continent. We hope that Bophelo Unit will be able to advance your contribution to patient outcomes. Dr. Inge Kleinhans, the unit manager, thank you for that strategic direction. Thank you for the strategic work stream. All I can say is well thought, well outlined, well articulated. Very best wishes in the implementation of the strategy to you and to your team. Prof. Chu, you spoke about the academic collaborations, intra and interdepartmental collaboration. You spoke how important that is towards before actually the grant call comes up. You spoke about collaboration that work for your center or your unit, the local NGOs. You spoke about international collaboration, and importantly, you spoke how Bophelo is positioned for strength, and I hope we all noted as in why and how. You spoke about being relevant, and I think that is key for this unit. We value advices, and we're looking forward to you being part of this journey with us. Dr. Maria van Zyl, you spoke about contribution of engineers to the vision of Bophelo. Who would have thought of engineers in this platform, incorporating engineering in surgical system, how data is crucial in predictions at patient, team, and international levels. How does data, or how can we use data to improve patient outcome? That came out very clear. And I have no doubt that Bophelo will be all about this. We appreciate your future contribution to this unit. Dr. Sat, you reiterated the importance of teamwork, collaboration, not working in silos. Once again, we are quite thrilled about your collaboration with the Bophelo Unit here at SMU. Professor Salome, Safe Surgical Care. You spoke about how Bophelo Unit can bridge the gap within academia and improve or contribute to policy and practice through its data, so to strengthen surgical systems. We also look forward to the partnership that you will have with Bophelo Unit. In closing, allow me to end with a response by Michelangelo when he was asked how he went about his sculpting process. He said, "I saw the angel in the marble and carved until I set him free." We hope Bophelo Unit will set free the use of data to improve the lives of our communities and healthcare workers, and serve as a beacon of hope and collaboration and transforming surgical care within our beautiful country, continent, and abroad. Thank you all for attending, the organizers, speakers, supporters, partners. Let us all depart in peace. Prof. Clays and the team, we have now officially cut the ribbon. From all of us, congratulations and thank you.
Thank you very much, Prof. Majani, and thank you again to all our speakers, collaborators, colleagues, and everybody joining us today. We look forward to the collaborations and learning that will emerge from this next chapter. Have a good afternoon, everybody.